I must say, I've been giving talks for 15 years. I don't think I've ever once followed singing. That's the first time. And it was very nice. It's a nice way to kick this off. It's also a nice way to underscore what it is that we're doing here. We're trying to help people move on with their lives. We're trying to help people to get OCD. Get our microphones up. I'm tall. There we go. Yeah. That's all right. That's fine. Am I right? Okay, good. So I'm going to jump in. My goal today is to present some information about obsessive-compulsive disorder and its treatment. I'm also, because of the work that I'm doing these days, is sort of branching out beyond OCD and including some of the disorders that seem like second cousins, sometimes first cousins, sometimes second cousins. Trichotillomania and also tic disorders. I'm doing a lot of work in those areas too. My goal is to kind of give you a comprehensive view of what it is that's going on these days in our lab and maybe even beyond our lab in terms of what we know about treatment for these disorders and what it all means for you in terms of implications for asking questions of treatment providers about what they're going to do and why they're going to do it. Hopefully the research background here will be helpful in helping everybody think about what questions to pose. And for those of you who are therapists, how many mental health providers are out here? Oh, quite a bit. So hopefully this will provide an update of some information that's been sort of out there, and now I can synthesize for you in terms of where the literature is going in all of these areas. Okay, so with that said, I'm going to focus, there's another thing you'll see. Over the last 15 years, when I came to the Center for the Treatment Study of Anxiety, my work was primarily with adults. My background is both in adult and child treatment, but these days my focus has been on treating younger folks, so 17 and down. What I'm going to try to do as we go is talk about examples from both, but I'm going to talk a little bit in particular about the phenomenology of OCD in children and adolescents because it may be different than what you'd expect to see in adults. This part's not different. This is a definition of obsessions. One thing I would say about this is it's important to recognize that obsessions are unwanted, unwelcome. They're not typically positive obsessions. When I hear people getting referrals, my child is obsessed with the Philadelphia Eagles, for example. You start finding out pretty quickly that parents may not mean that in the way that we mean that. Obsessions are unwelcomed. And one thing with kids is that kids don't always describe these things as being anxiety, the feeling that comes from these thoughts. They describe it in other ways. They may describe it as just things I don't like, thoughts that pop in my head, things I don't want to have, things I find yuck. I mean, you have to find the kid's vocabulary for this. But with everybody across the spectrum with OCD, we're talking about something that pops in, unwelcomed, troublesome, bothersome, and then they want to try to make it go away. And the ways of making it go away are going to be talked about some more in detail, and I think it really becomes the crux of the whole treatment, is helping people to recognize that attempts to make obsessions go away are the fuel for OCD. Whether it's sort of formal washing, whether it's imaginal things in your head, sort of imagining the dirt falling off you, those kinds of things, mental rituals, whether it's desperately distracting yourself, the methods you're using to try to make the thoughts go away is actually very important to treatment. And from treatment provider perspective, I always ask people, so you got an obsession when? When was the last time you had one? And typically it's like, well, it's in the waiting room, or I'm having one right now. I say, good, okay, so walk me through. You got it? What were the words? Was it a word or a picture? And when you did get it, what did you do next? Like, what happened next? Because what happened next, if I ask them did you do any compulsions, people might say, not that I know of. But if I ask them what happens next, I might get more about into the detail of how they're making the thoughts go away. And that's critically important when you're trying to help somebody out. Okay? Another thing to note is just because the content is unusual doesn't necessarily mean it's not OCD. These are some just common examples that we've run into with kids, certainly seen some uncommon examples with adults. It ought not to be a cause for concern. You're looking, if you're worried about things like thought disorder, you need other evidence for thought disorder. OCD can range from the typical dirt germs checking because I'm afraid I'm going to lose something to things like this. Really need to pay attention to that. In terms of the compulsions I just mentioned, the anxiety is associated with the obsessions. So the person gets a thought, they get anxious, they get scared, they get nervous, they get fearful, they're afraid something bad's going to happen. So you hear the anxiety rising, and the compulsion is the thing that they do to try to make that anxiety go down, or to also prevent something, dreaded event from happening. So the reason most people check is because they're afraid something bad's going to happen if they don't check. For contamination, you got some people who say, I'm washing my hands in order to decrease the chance I get sick or get somebody in my family sick. For other people, that can also be about disgust and it just feels yucky. I don't know why it is. I know I'm not going to get sick, but I'm still worried. We'll talk about the implications for that for treatment later on. The cardinal feature of OCD is neutralizing. Tennis in your head is the way I put this to people. So the OCD serves and you return serve. The OCD serves, you return serve. Sometimes it's about replacing, it can be as formal as replacing bad thoughts with good thoughts, bad words with good words, bad pictures with good pictures, and those are the kinds of things that as a therapist you can become very interested in trying to understand that process so you can help the person modify what they're doing in the presence of these obsessions. And that's true for adults, it's true for kids too. These are just a couple of examples of mental rituals. I can recall treating somebody once who came diagnosed as, quote, a pure obsession. This is a long time ago. And he gave me an example, and he'd been treated unsuccessfully with exposure response prevention, which struck us a bit odd. And so I started talking to him as a teenager. And I said, well, walk me through the last set of obsessions you've had. And his obsessions involved having his girlfriend eaten by sharks. Now, no trauma history, never ever seen anything like that, just had this intrusive thought that his girlfriend had been eaten by sharks. And what I asked him to do next, because I didn't quite understand it yet, he says, okay, well, walk me through the whole thing. And he says, I have this picture in my head of my girlfriend being eaten by sharks. And then I'm sitting on the dock, I see this happening in the bay. I get out of my chair, I jump into the water, I swim out to the shark, I present myself to the shark, I punch the shark in the nose, like they say to do. The shark lets go of her, bites me. And then what happens? And he says, the last thing I see is the shark going under the water. And I said, how do you feel then? Nobody ever asked him that. And he said, better. Better. So part of that is an obsession, part of that is a compulsion. And that's why the treatment wasn't working, because they were doing exposure to the whole thing. And so what we needed to do was to break that apart so that we were really focusing on treating the obsession with the methods that work for obsessions and treating the compulsion with the methods that work for compulsion. Very important kind of thing to try to parse out. Because the second part of that, where he's sitting on the dock, that's where it turns from obsession to compulsion. He's sitting on the dock. When he gets up voluntarily out of the chair and jumps into the water, we've just gone from obsession to compulsion. Really important stuff to look for. Because that's the intentional part, remember I said? That it's designed to neutralize. So he's doing that part to get rid of the first part. Boom. But really important treatment implications. Anybody ever raise a 4-year-old? Ever read stories to a 4-year-old? You ever try to do the short version? I have on occasion, I admit. And I'm reading to my 4-year-old, and I'm going through, and it's dense wording, and you're kind of doing the Reader's Digest version, and it'll stop you in the middle. And my daughter would, very direct, she'd say, Daddy, you're skipping words. And, that's not compulsive. That's normative kid stuff. Kids do a lot of things that look like they might be compulsive. Sometimes they're about trying to learn how the world works. They're asking a lot of questions because they don't get things. So when you're really trying to differentiate OCD in kids, especially little kids, from regular old kid stuff, you look at things like timing. So a kid who has trouble with not having a special teddy bear at 13 as opposed to at 4, those are the kinds of things that start to get me to pay attention. The content, that can also matter too, so there's a lot of developmentally appropriate stuff that kids worry about at age 4 that they don't worry about at age 13. So you start paying attention to that as well. The function, is this the kind of thing that's helping the kid learn how the world works, or is it keeping them stuck? They can't go outside because they have to pursue these particular repetitive behaviors. And severity and functional impairment. If your good night time with your kid takes 45 minutes to an hour, as opposed to it's a special thing that we do together, we say it the same way every night, we're done, then we start to worry about whether we've crossed over to OCD as opposed to kind of normative kid stuff. And most kids with OCD have both, which makes this tricky. This is some ways that you can notice functional impairment in kids. I think we certainly know with adults, things like underemployment, unemployment, difficulty with school, dropping out of school. With kids, you see things like this, that they lose a lot of time to obsessions, compulsions. I can't tell you how many times I've had kids say, I can't do my homework, I don't have the energy, I don't have the time. And then they get behind academically, and the more you get behind academically, the harder it all piles up, and then you start taking cumulative tests in geometry, you don't do well, and that sort of dampens your enthusiasm for continuing. Next thing you know, you're stuck, and you may even be out of school. A lot of the kids we see haven't been to school in quite a while. They withdraw from social contacts. I've had many kids say, I just don't have the energy to pursue my outside activities. They stop seeing friends. They don't have people over. Sometimes not having people over is because the other people are contaminated. But sometimes it's not even the subtype. It has nothing to do with that. It has to do with just, it's so hard to be under siege for so long, especially if I have to try to keep it together at school. After school, just go up to my room and leave me alone. And that's, go up to my room, leave me alone. It has other implications for whatever reason you're going up to your room to be left alone. And you stop getting invited places, you kind of get derailed. I think that's the way to think about it. You start getting off on a path that's harder to get back to developmentally where you need to be. That's another important reason to kind of catch this stuff early, so we don't have a lot of derailing and losing ground. So the things we use to evaluate OCD, I'm going to go through them pretty quickly. First off, we tend to, this is for a research study that we did and are doing, we've got a couple of these going. I like to interview kids in the presence of the parent. I did this on Friday. So I have a 15-year-old girl. I'm directing my questions at her, because she knows better than I do. She knows better than mom does what's going on in her head. Mom might have information about that kid's functioning, about kind of how long things are taking, that the kid's not going to notice. So I set up the interview that way. I say, look, you're going to know stuff that nobody can know. So I got to ask you. But I also want to get everybody else's perspective so I really get a good idea of how much time this is taking up, how much it's affecting you, because you might not be noticing that so much. It's not about who's telling the truth. That's why I'm doing that. I don't want to get into, it's 3 hours. No, it's 15 minutes. I want to cut off that conversation the first time I meet this family. And so I want to make sure I'm asking the questions in a way that says, look, I got to get the most accurate information we can possibly get about how OCD is messing stuff up for you, so we can help figure out what we're going to do about it. So I try to set it up that way. There are exceptions, though, and there's some contents of OCD that are more difficult to talk about in front of your parents than others, such as sexual obsessions. And I might check out with the kid, you got any things that are going on OCD-wise that OCD's throwing at you that you just can't talk about with mom hanging out here? And the kid goes like this. Yeah, so, Mom, what do you say you go get a cup of coffee? And we can bring her back in at the end. Or Dad. I've seen dads, too. Dads, I'd say, I actually looked at this recently. About 20% of the kids we see at intake have got mom and dad there. And 80% have had one or the other. I mean, obviously work schedules being the life. But I really think it's important as you evaluate and treat somebody that you get eyes on everybody if you can. Because they're going to make different contributions to helping out that are going to be invaluable. And you got to know who's the person who gets tended to ask those reassurance questions and who doesn't. So as much as you can, you want to know what are the strengths in the family and how does everybody collectively deal with this OCD stuff when it comes up. We want to talk about severity. We use a thing called the Yale-Brown Obsessive-Compulsive Scale. It's an interviewer-rated measure. One of the things I like about that, and I did this on Friday too, is I'm sitting there, and I wave this thing. I say, I have a 6-page grocery list of obsessions and compulsions here. I'm going to ask you all these questions. What do you suppose it means that I have a big, long list like this? And she looks at me and she says, well, I guess other people have this. Right. Other people have every single one of these things. You may have only a few, but other people have had these, and I'll bet there's some stuff that's not even on this list. I'm already telling the kid, I've heard this all the time, this is not new to us, and it's okay to talk about this because that's the nature of OCD. This isn't about you. It's about your illness. And I think that that's becoming more and more my stance, even as I talk to adults. John March's language, externalizing OCD. John March is a child psychiatrist who wrote a textbook on cognitive behavioral manual on treating OCD in 1998. He's revising it now. He's a close collaborator of mine. I think that's probably the single most important thing in that book, is instead of asking a kid or even an adult, how much did you ritualize this weekend? That's a different kind of question then. So tell me how much OCD was bugging you on Friday and Saturday. It's got a different flavor to it. It's more collaborative. It's more about it giving you trouble rather than, did you make everyone late? And right off the bat, you've got a combative, you don't have the kind of collaborative feel if you're going to ask the questions that way. So I tend to ask them just as a third person in the room. I often do that. I have an empty chair in my office. The old Gestalt therapist in this room might remember this stuff. And I kind of look at it. How much is he here with you now? Was he bugging you in the elevator? Is he bugging you because you had to come to the city? It's not about you. It's not about your being irrational. It's about it. It. And with the little guys, we asked them to name it, which I'll get into more later on. So we use a diagnostic interview. That's just one. It's a big, long, researchy one. There are shorter ones, but OCD often comes with other things. Do you want to know about those other things? The first other thing I tend to look for is depression, both in adults and kids. I want to know about that. It's hard not to be depressed when you can't go to school, and you can't see your friends, and you can't work, and you can't function. And what I would say is it's really important to know not only that whether or not there's depression, but how much and how much is it impairing, because it's got treatment implications. And for a subset of people, I'd say the treatment that we have to offer in the CBT for OCD, it's going to take a lot of energy and enthusiasm. And if I got somebody who's so depressed they can't do it, I'd rather target that first. But on the other hand, we've got some research studies saying that we can often get 2 birds with 1 stone in terms of treatment. If we can focus OCD treatment with somebody who has comorbid depression, it's not severe, you can see reductions in the OCD and reductions in the depression without really targeting the depression. And conveniently enough, some of the medications people use for treating OCD, the serotonin reuptake inhibitors, are also antidepressants. So that's another way to think about, you've got somebody who I just don't think they've got the optimism and the energy to do this treatment right now, I often will make a medication referral at that point. Say, come back when these things are in better shape, where you're better able to do what needs to be done with the OCD. The tick scale we use here is, I just bring this up, we use the Yale. I think it's important to know about tics. I also think it's important to know about the difference between tics and compulsions, because there's some things that look like compulsions that are actually tics. There's some things that look like tics that are actually compulsions. And I'll get into the difference between those things. They've got some treatment implications, which we'll talk about later on. Yeah, I covered that. The SciBox, if you haven't seen it, it's a primary symptom scale, 0 to 40. People typically come in on the SciBox in the mid-20s. Again, it's sort of a severity scale for OCD, gives us clinicians and researchers a sense of how severe things are, how much impairment there is. The typical entry criteria for a research trial is 16, suggesting that there's some OCD we think is subclinical. When I see somebody who's a 10 or down on the SciBox, I typically would recommend a self-help book, and also then some ongoing booster sessions or contact, because 10 or down is pretty good. There have been some studies of OCD symptoms in people who don't have OCD using this same measure. And the typical walking around adult and a college student, they did this both ways, adults and college student, has a Y box of about 3 or 4, suggesting something really interesting and important. Everybody, every single person you know has an occasional, unwanted, unwelcome, intrusive thought, idea, image, or impulse that pops into their head they don't want to have. And every single person that you know has an occasional thing they do to make some distress go away. It's ubiquitous. And so that raises some interesting questions about what do we do about that? And what I do about that, I tell people that. So if your goal is a clear mind with no obsessions, we got to change your goal. Because I don't have that. And I don't have OCD. So we got to change that right away. It's not whether you get an obsession. That's really important. It's not whether you get an obsession. It's what you do when it comes in. And if you get the treatment focused in that way, you're really going to help cut through all the confusion about, SUDs and all sorts of stuff. That's the treatment. Change what they do when an obsession comes in. Teach them how to do it. That's your treatment. Yeah, boring. Okay. Some other things we use, I like to get a nice developmental history. What's been this kid's life, what's been this adult's life too, over the course of time, without too much detail, because the treatment is very focused on the here and now. And that's another thing that people often say, if they're not familiar with CBT, they want to tell me the story about when the treatment, when the disorder started. And if it's 30 years after the fact, the information, it's valuable to hear it. I want to hear specific personal story, but it's not going to have particular relevance for what I'm going to do now. And I want to make that point really clear. I don't think we need to know the answer. Because I don't think we can know it. I think it's so complicated. I think it's neurobiology, genetics, environmental stuff, stress, why it started. We're going to be at this for another 20 years. We're still not going to have a good answer. But for treatment purposes, cognitive behavioral treatment, it doesn't matter. It doesn't make a difference. Here's what you got now. Here's what we need to do. So I'm not worried too much about not being able to identify why here and not there, why her instead of this one in SIBS. I don't know. It doesn't matter. That's not the issue for treatment. So I ask about anxiety, I ask about depression. I also want to know about internalizing and externalizing symptoms. So kids who are, and oftentimes you see kids, and I know those of you who are struggling with OCD in your families have seen that your kids can get pretty upset and talk back and get, sometimes, occasionally we see violence. I mean, kids really don't want to confront their OCD, and they really get overwhelmed pretty quickly. You see sometimes these kind of behaviors popping in. So you want to know that as well when you're thinking about treatment, because if you don't have a plan for that, then you need to, you're going to have a family that doesn't know how to handle that when it does come up. Anybody ever heard of this thing? PANDAS? Pediatric autoimmune neuropsychiatric disorders associated with strep. I used to have a little panda I could put up in the corner, but crashed. The basic idea here, it's sort of an intriguing idea, is that there's a subset of people who get OCD, almost like the old Donald Sutherland movie, The Invasion of the Body Snatchers. Like you go to bed Tuesday night and you're fine. You wake up on Wednesday morning and you've got obsessions, compulsions, tics. It's typically male. It's typically before the age of 12. And what's interesting is if you look at their history, you've got anywhere in a couple of weeks to a couple of months, the window's too wide for us to know what that means, but a couple of weeks to a couple of months before that dramatic onset of OCD, you've had a kid with strep. Strep infection is associated in a subset of these kids. And it's not just once. It's that the kid gets strep, gets this dramatic onset OCD. You treat the strep and it goes zoop, back down. Kid gets reinfected, as kids often do. Half of kids in school get strep at some point. You see another dramatic increase, up, down. In order to count it as pandas, you need 2 of those dramatic, the sawtooth pattern is the way we put it here. But it does have some interesting implications. There happens to be, I guess relatively speaking, in the backyard, Josephine Elia at CHOP is a pandas expert. So if you have one of these cases, or you happen to have somebody in your family who you think this pattern fits for, Josephine Elia at CHOP, and also NIMH are doing a ton of research on this. But I'd say my feeling about it, and we've actually studied this, published a paper on it in 2002 with John March, is it doesn't characterize most people with OCD. And it's an intriguing window into the brain, but I don't think it covers most. Okay? So I'm kind of working through what I'm asking, what I want to know, what else do I need to know in order to help somebody with OCD. In particular, I want to know what they're good at. I want to know what they've learned how to do. If I've got a kid who's musical, I want to know about that. If I get a kid who's into sports, I want to know about that too. Because I'm thinking already that this is a kid who knows something about repetition. He knows something about how to persist. She knows something about how to continue to do something and getting better at something over the course of time. I need that because I'm going to be using those kinds of metaphors. When I'm asking, this is sort of a funny thing I run into from time to time. My first intake, I'm often asking the kid about soccer and what position do you play, and the parents are like, "Will you get on with it?" And in the back of my head, I'm like, I am getting on. Because later on, when I know, I had a good example of this recently. I know I got a kid who wants to go to horseback riding camp next summer. She's a teenager. And I'm sitting there doing exposure with her. And in the back of my head, because I asked her about these questions 6 weeks before we started, I know that's there. And so when we start to get bogged down on doing exposure, I bring it back up. I say, this stuff here in the bathroom is standing between you and going successfully to horseback riding camp. Because I don't see how you get to horseback riding camp, overnight camp, without confronting these public bathrooms. It's going to be too hard. So I'm going to try to frame that exposure in a way that makes it work for her. And when I talk about exposure, I'll talk about that some more as I go on. But that's the basic idea. I want to know this kid well enough to know what matters to them. Because if I start telling you ever tell a kid this is going to be really important for you in college, and they're 9, this has implications for later. What kind of job are you going to get? Dad, I'm 10. Who cares? So you want to try something that's more relevant. Family environment, I want to know, and this is true for adults too, I want to know how supportive it is of the person, and also how supportive it is of the OCD as well. Do we have people in the family who also have OCD, which is certainly possible? And what are the implications of that for treating the person? So if I'm asking somebody with contamination fear to touch their bottom of their shoes and go and grab their fork and touch the fork, and now go eat lunch, and I've got 2 other people at the table with OCD who say, not in my house, right? I've got to deal with that. I've got to set that up front. So I need to know enough about what's going on in this family to be useful to them. So how entangled in OCD are they? I need to know that as well. There's some people who are more entangled than others, and I think there are people who might be able to be more supportive than others because they're less entangled. So you want to know about that too as you're thinking about treatment plan. So you have what you need. Now what do you do? Pitching CBT. It sounds like marketing, doesn't it? And it is in some ways. My job at this point is, okay, we've evaluated, we think you got OCD, and now my goal is to let you know about something that you may or may not know about, which is the efficacy of a treatment that's been tried and tested since Victor Meyer in the mid-1960s. It's been used quite a bit in the last 10 to 15 years with kids. We got a lot of information about it, and I want to share that with you so you can make an informed decision. I'm not trying to sell too hard, right? Because I don't want to have somebody sign up reluctantly for a treatment that's going to take a lot of effort on their part to put into place. We got other choices out there. People can wait. I'd rather get something. If you think about this in terms of, I'm a University of Rhode Island student, and Jim Prochaska is a guy who worked there when I was there and is still there, and he has created a thing called the stages of change. which is used a lot in smoking research. But basically what you get is it's important to pay attention to where somebody is in terms of their readiness for change.